Okay, so we are live. Hopefully everything is good. Okay, so well, okay. Good afternoon, ladies and gentlemen. Let me know who is online. Write your name in the chat box. We will have an interactive day today and lots of questions to prepare ourselves for high yield questions at 2CK. Let me know your name in the chat box so we can have the interactive part of the course. Okay. Hello, Zinai Gandu. I'm pleased that you participate, and I'm looking forward to your answers, actually. Okay. Nevertheless, let's just get ahead of ourselves and talk about 36-year-old female. She comes to the ED department with right lower quadrant pain. She had some nausea and some vomiting prior to this episode, 2-3 days before. Okay. Well, the thing is that she says that the last 4 weeks she did not have any menses. And the question is, what is the best next step? A, we go for an ultrasound. B, we do a CT scan of the abdomen. C, we do a beta HCG. And D, we determine whether or not she has ANA. Let me know your answer in the comments or in the chat box. Well done, Zinai. It is a C indeed. It's a beta HCG. Any right lower quadrant pain in a fertile female has to be screened firstly for beta HCG to determine whether the patient has an ectopic pregnancy or not. However, now we have the second part of the question. The beta HCG comes out negative. Other labs are done to see what's her status, and to our surprise, she has high neurofunctional tests, so high AST and ALT. When asking the next question, the examiners want to know what is the most likely diagnosis. So we have here acute appendicitis, colorectal cancer. We also have Meckel's diverticulum, and lastly we have Crohn's disease. Let me know your answer in the comments or in the chat box. Hello Ahmed, pleased to meet you. So we have an A, acute appendicitis. Are there any other answers? What do you think, Zinai, of it? Okay, so there are 1C and 1A. When a test such as beta HCG returns as negative, we have two clinical scenarios. Either the patient has acute appendicitis or she has an IBD problem. The differentiating factor might be the clinical presentation, such as a patient that comes with mucus stools, or that has uveitis, which can be seen with IBDs. On the other hand, this patient has high LFTs. Although usually the high AST and ALTs are associated with ulcerative colitis, this does not exclude the other IBD to be involved, namely Crohn's disease. The sign of high AST LATs is a sign of autoimmune hepatitis. Okay, so the correct answer here is D, Crohn's disease. Now, let's recap a bit how to think about these types of questions with fertile females presenting with right lower quadrant pain. When a female comes firstly with right lower quadrant pain, we screen it with beta HCG as we saw in the first part of the question stem. Then our thinking splits in two. If the patient has high beta HCG, it means we have a suspicion of ectopic pregnancy. We opt for the ultrasound, and if the ultrasound confirms ectopic pregnancy, we go for an exploratory laparotomy. On the other hand, if the ultrasound shows no ectopic pregnancy, but the vaginal ultrasound shows a pregnancy, the screening is done for fever and pain that started at the umbilicus. In this case, we ultrasound again for acute appendicitis. If the beta ECG is low, there are two clinical scenarios, as we've discussed: IBD versus acute appendicitis. IBD is suggestive from the history. The patient will have bloody diarrhea or mucoid diarrhea. The patient can have malabsorption. Another case is represented by associated autoimmune conditions such as autoimmune hepatitis. Further down the line, we screen her with colonoscopy and we put the diagnosis of IBD. On the other hand, systemic symptoms such as fever, the pain that started at the umbilicus and now it's in the right lower quadrant, the sign of the obturator or the Rovsin sign are all suggestive of acute appendicitis. Already having the negative result of pregnancy, a CT scan is prescribed to identify acute appendicitis. Okay, this is the algorithm to treat abdominal pain in females. Ahmed and Zinai, do you have any questions? Okay, it seems there are no questions on this algorithm, so we will pursue further. Uh, 30 years old female at 39 weeks gestation is in the delivery room. After delivering a child with APGAR scores of 8 and 9 at 1 and 5 minutes, she starts bleeding profoundly. Much more, she has abdominal pain, and there is a mass protruding from the vagina. Despite these measures, the patient continues bleeding with having a contracted uterus at palpation. What is the best next step? So we do laparotomy for hysterectomy. We retry to manually reduce the uterus. We administer indomethacin, or we restart the oxytocin drip. Let me know your answer in the chat box. Okay, so Zinai, Ahmed, and other participants, what do you think the answer is here? We have an A, and we have indomethacin. Thank you, Zinai. Thank you, Ahmed. If other participants logged in, please let me know your name to have an interactive discussion. Zinai and Ahmed, I appreciate your answers. Now let's see what's the underlying process of thinking here. This patient has a uterine prolapse. The uterine prolapse is easily recognizable by having the uterus protruding from the vagina. Indeed, there is bleeding and abdominal pain, but this can be also seen with things such as continuous bleeding due to uterine atony. Now, in the algorithm for treating a prolapsing uterus, the mass or the uterus is reduced manually as a first step. The next steps are on the contractility of the uterus. Firstly, the uterus has to be without influence of uterotonics such as oxytocin. This is why the gynecologist opted for stopping the oxytocin. The persistence of its contraction, as in this case, having a contracted uterus, requires further administration of uterorelaxants, such as indomethacin. Therefore, the correct answer here is C, administer indomethacin. However, if even after administration of indomethacin the uterus cannot be reduced manually, then laparotomy with hysterectomy is performed. Let us see the algorithm. In the management of the uterine prolapse, we start by replacing manually the uterus. Afterwards, we cease any uterotonics such as oxytocin. Then we administer uterorelaxants such as indomethacin if there are signs of continuous high contractility of the uterus. Lastly, we perform laparotomy with hysterectomy as a worst case scenario solution. Are there any questions on this topic? Thank you, Ahmed. And also thank you, Ahmed, for the participation. Okay, it's time to switch gears. We have a 75-year-old male. He comes after a Christmas party with the family. He sensed a lot of palpitations. Starting from the Christmas Eve. He's now in the ED department. 27th December. On the EKG there are no discernible P waves with an irregular rhythm. And the question is, what is the best next step? We can anticoagulate him by giving him warfarin. We can perform an electric cardioversion. Also, the patient has a heart rhythm of 19 beats per minute with a blood pressure of 120/80 and a temperature of 37 degrees Celsius. The other variant is to give him beta blockers, and lastly we perform transesophageal echocardiography. Let me know your answer in the chat box. We have a new participant. Would you like to introduce yourself to have a more complex discussion during this class? Zinai says C, Ahmed says D. The new participant says what? All the new participants, I would urge you to let me know your name in the chat box so we can have a free discussion. Now, let's pursue with the answer. This patient indeed has atrial fibrillation. Now the question is, how long did the AFib take place? We know it started on the Christmas Eve. This is 24th. Now he's on the 27th December. The first step when treating atrial fibrillation is to control for the rate. As Zinai pointed out, the control of the rate is done with beta blockers. However, the control of the rate is an initial step taken for all the patients that have a rate higher than 110 beats per minute. Our patient is at 19 beats per minute. This means he does not need the beta blocker step. The next step is to control for the rhythm. The control of the rhythm is dependent upon the time that lapsed between the initiating factor or the initiating of atrial fibrillation and the moment of presentation. In our case, the patient has 3 days between when AFib starts and when he comes to the ED. If the patient has less than 24 hours from the beginning of atrial fibrillation, then we can pursue cardiac electroversion without doing any screening. However, if more than 24 hours lapsed, we need to screen him for eventual thrombi. The screening is done with transesophageal echocardiography. Therefore, the correct answer to the question is D, DEE. The problem is with this patient that despite doing TEE, which is normal, trying to do the electrocardioversion, yep, which fails. Question is, before putting him on the antiarrhythmic drug of choice, the patient requires a screening that consists of what? So we have liver functional tests and abdominal CT scan. We have renal function, so renal functional tests, and a lipid panel. We have TSH and a chest X-ray. Lastly, we have an EKG and an ultrasound of the carotid. Let me know your answer in the chat box. Okay, the answer is we perform a TSH and a chest X-ray. Amiodarone is both a pulmonary toxic leading to interstitial lung disease, as well as a thyroid toxic leading to hypothyroidism. To refresh a little bit the AF algorithm, we have to think like this. First step in treating AF is to do a rate control if the patient has more than 110 beats per minute. We give him beta blockers. Afterwards, we perform rhythm control. Less than 24 hours from the beginning of the AF, we perform electrocardioversion. More than 24 hours, we perform a transesophageal echocardiography, and then we go for anticoagulation, heparin with warfarin, if there are thrombi. If there are no thrombi, then we perform electric cardioversion. If cardioversion fails, then we have a persistent atrial fibrillation, and we try to control it with drugs. Usually we control it with amiodarone. Other alternatives can be sotalol or defetalid. But prior to amiodarone administration, we perform a chest x-ray and a thyroid test. Okay. Let's do the last question of the day. We have a 25-year-old who was lone moaning. He started to have some pain in the left eye, such excruciating pain that he comes to the ED. He has a gritty sensation in the eye, redness of the conjunctiva, but at the eye examination there is no finding. What is the best next step? A. Emergency globe surgery. Let's say call it ocular globe. Antibiotics. Fluorescein dye exam, or reassure and send home. Let me know your answer in the chat box. Okay, so Zinai says C. Are there any other answers from your part? In this case, we have an open globe trauma. In the case of open globe trauma, there is firstly the eye exam. If the object is clearly seen, there are 2 steps to take. Firstly, there is an emergency globe surgery. Secondly, there are prophylactic antibiotics. In the case when the object cannot be seen, such as in our case, we perform a fluorescein dye exam, which will show the piercing of the globe where the object entered. The open globe trauma can occur with needles or while lawn mowing. It is an ophthalmology emergency. As I've told before, if the object is visible, we perform surgery and prophylactic antibiotics are given. In the case when the object is not visible at the eye exam, we perform fluorescein, not fluoroscopy, a fluorescein dye exam. Okay, are there any questions on these topics? There are no questions. If you like this type of content and want to see more, please subscribe to the channel and give a like to these classes. Have a nice day ahead. Thank you, Zinai, and thank you, Ahmed, for your participation. See you soon.